shaped in a special way. It is shaped so that the palatal aspect has a horizontal shelf. The horizontal shelf allows the lower incisors to contact that horizontal shelf at 90 degrees. It's really important that that contact is at 90 degrees. Otherwise, if it's not, we'll get not the anticipated movement. The anticipated movement that we're looking for is in fact those lower incisors to be pushed downwards and to be intruded down their long axis. If of course we don't get that, and if we don't get that horizontal shelf, it means that the lower incisors will be hitting on an inclined plane and the lower incisors will between all the back teeth. The dial appliance itself is reasonably comfortable, so it's well tolerated by the patient. The posterior teeth are obviously out of contact, and it will take probably 1 week or 10 days for the second or third molars to come back into contact. So to start off with, our patient will feel slightly different. He'll only be able to bite on his front teeth, but within 7 to 10 days, with the posteriors starting to over-erupt, he'll have a tripod. It's really important. Dentistry, we deal with tripods all the time. He'll have a tripod of anterior tooth contact and posterior tooth contact, and at that stage he'll now feel comfortable. And of course, one by one, the posterior teeth will come into contact. So the molars first, then the premolars, and the ones that take the longest to come into contact will be the canine teeth. Now that process can take anywhere between about 6 weeks in a young patient up to 6 months in an older patient. But the lovely thing about it, it's minimal interventive dentistry. You're not going to be having to grind teeth down at all. And when you take the dial appliance off, you now have space. You have the space to be able to go and restore. So here was our initial starting position with the lower incisors contacting. The lower incisors have been intruded, so the dial appliance gives us a combination of intrusion and extrusion of the posteriors. That gives us space to do some non-preparation porcelain veneers, and they are then fitted onto the palatal aspects so that we have restored our patient. Let's take the dial appliance a little bit further now, and we can use this dial appliance to create space, to increase vertical dimension, and also to aid us in formulating a new occlusal scheme. So let's look at the occlusal concepts behind the dial appliance. We have a gentleman here who, when we look at his face, you would probably look at him and say his lower third of his face is overclosed. He has certainly some problems with his lips. This is his normal smile. This is his smile that's enforced. And the first thing we look at is his lips look strange. His upper lip does not look natural as he is smiling. And that's because he's got no teeth in that envelope when he smiles normally, and he really has to force a smile to be able to show his teeth. This is him with his M position. Now the gentleman's about 40 to 45 years old. We should be seeing teeth in here. If we're not seeing teeth in there, that usually means that we've lost vertical dimension, and the natural compensatory mechanisms are not catching up. We should be seeing, probably with a 45-year-old, 2 millimeters of lower tooth, 2.5 millimeters, and maybe 0.5 millimeter of his upper tooth, but there's nothing there at all. This is his smile. That is his maximum smile. We look inside and we see this situation. So this is where his upper anteriors. This is overclosure that's occurred, and of course when the mandible does overclose, we go from what he probably was at some stage a class 1 occlusion now into very much a class 3 occlusion. Our problem with a class 3 occlusion from an occlusal point of view is we have no guidance, and guidance is absolutely essential in order to create a good working masticatory system, free from stress, free from pain, and also the ability for us to put restorations in the mouth and know that the restorations are going to succeed. So the first thing that we've done is whiten his teeth, and we're now going to look at the goals for our treatment. The goals for my treatment are going to be to provide him with a reorganized occlusion, And there's certain aspects, there's certain principles that we need to be involved here in this reorganized occlusion, so we get stability, we get pain-free dentistry, and we have no problems with the masticatory system. Our first one is that the retruded contact position, the intercuspal position, should be coincident with the condyles in their ideal position. The ideal position is retruded axis position. That's the position of the condyles in their most superior, slightly anterior position, in an unstrained, muscular, relaxed position, with the disc inserted in the normal position between the condyle and the articular eminence. So it's this sort of position on a dried skull, very difficult to show without having the disc there. But it's not at the 12 o'clock, it's around about the 1 minute past 12 position that we're looking for. And RAP has been accepted as this very, very useful reference position because we can get to it time and time again. I can get to RAP for my patient today, tomorrow, 5, 10, 15, 20 years later. I can teach my students, and I do teach my students, so they can achieve that same position. So I can have 20 patients, 20 students with me, all finding that same position. The other position that we can work to, the position of the condyle that we work to, is intercuspal position. But intercuspal position changes on a daily, weekly, yearly basis. Any dentistry that we do that maybe is not of the highest quality changes intercuspal position. When somebody wears their teeth, then intercuspal position changes. During the daytime, morning and evening time, our intercuspal position changes. So it's a very, very difficult position to work to with any degree of accuracy because it's changing all the time. What we don't want to have is a discrepancy between intercuspal and the retruded contact position. We call that a slide. And as you can see here, this is a dentist who was on one of my courses back in the UK. His retruded contact position is at the back of the mouth somewhere on his third molar. He had an over-erupted upper third molar. And this was his discrepancy between his retruded contact position and his intercuspal position. As you can see, there is a large vertical and horizontal slide there. Before we do anything else in terms of good restorative dentistry, stable restorative dentistry, we have to eliminate the slide. That's occlusal adjustment to eliminate the slide. That then places our condyles back in that ideal muscular, relaxed, stable, reproducible position called RAP. Our second thing that we need to achieve is a mutually protected occlusion, where our anterior teeth protect our posteriors and our posteriors protect our anteriors. In this situation, you can see some anterior bridge work. It may look a little bit strange to you. The anterior bridge work has been deliberately made so it's over sized on the palatal aspect. It goes halfway down our patient's throat, and the reason for that, as you can probably appreciate, is we've got no teeth here, and the patient has got a class 2 div 1 occlusion. His class 2 div 1 occlusion means that his lower front teeth do not meet his upper partial denture. Over a period of years, he's been clenching and grinding, and he's been clenching and grinding on his back teeth. As you clench and grind on back teeth, that gives class 2 leverage, which is extremely stressful for the joints. If we are going to brooks and clench and grind, we want to brooks and clench and grind in class 3 leverage, not class 2. And by simply adding on these palatal ramps so that the lower incisors now hit here and here and here and here, we're giving the patient anterior tooth contact, and when he now brookses, he'll brooks on those anterior tooth contacts. That brooksing force is a long way away from the condyles and the temporomandibular joint, and that then gives class 3 leverage, not class 2, and that's as nature set us up. Next thing we've got to think about is anterior guidance. And anterior guidance is the influence that our teeth have on the way that the mandible moves. So we have anterior guidance, we have posterior guidance. Posterior guidance is the influence of the condyles, the eminentia. Anterior guidance is the influence of the teeth. And again, certain teeth have got certain functions to perform. As you're all probably aware, our anterior guidance is broken down into two different movements, protrusive movements and lateral movements. And ideally from our protrusive movements, we'd like to have the front teeth, the upper 4 and lower 4 incisors when we push our jaw forwards, discluding all the rest of the back teeth. Again, as we do that, we create, if the patient wants to brux, we're creating class 3 leverage again. And here's a normal standard patient protruding on his front teeth. If he bruxes there, it's class 3 leverage. Next thing we want to do is look at lateral guidance. And for lateral guidance, our ideal, as you're well aware, is canine guidance. And only really when the canines wear down, as in this instance here, do we move on to some form of group function. So our ideal is canine guidance. Our ideal is because the canines are obviously big teeth, they've got long roots, there's a big crown to them, there's lots of proprioception, and it's also much easier for us to create canine guidance than any form of group function. However, what happens when those canines grind down? When the canines grind down, very often we start to get loss of canine guidance and working side and non-working side interferences start to occur. And with the working side and non-working side interference, once we've lost our canines, as you can see in this instance, our front teeth wear down and our back teeth start to come into contact. And very, very rapidly, when our back teeth come into contact, we get large amounts of wear taking place. So this is the difference. If you can just look at these two slides are 10 years apart on the same patient. The slide here is for the patient who's been bruxing for 15, 20 years on their canines, bruxing in class 3 leverage on their front teeth. There comes a point when those canines wear down so much that we now have non-working side interferences coming to play. And as soon as the non-working side interferences come in, we then get class 2 leverage. Class 2 leverage is your traditional nutcracker. The nuts break very, very easily with minimum force. And within 2 or 3 years, then the back teeth break down very, very rapidly. So one of our goals of occlusal therapy is to make sure there are no non-working side interferences anywhere. And our final goal is that of posterior stability, to make sure that we have good contacts down the long axis of our posterior teeth. We have tripodized contacts. We have cusp to fossa contacts, not cusp to marginal ridge relationships. And that gives us that posterior stability we're looking for. So with those thought processes in your mind, we'll now go back and look at this same case. So here's the gentleman with his worn front teeth. He's in a class 3 relationship. He's got no anterior guidance. We have to try to increase his vertical dimension. We have to give him overlap, overbite and overjet. We have to give him a class 1 occlusion so that now we have anterior guidance on his anterior teeth, so that when and if he bruxes, again, he bruxes in a controlled fashion, which is class 3 leverage. Part of our marketing, part of our sales technique, and also treatment planning is to show what our patient is going to look like once he's had his work done. We can do that obviously with diagnostic waxing, but we also do that with cosmetic imaging. Once the imaging has been done, then we do our diagnostic waxing, and again here we've opened the models up, we've opened the vertical dimension up by 3 to 4 millimeters anteriorly, and of course as soon as you do that and open the vertical up, the anterior teeth drop backwards because we're on a hinge, and straight away we start to develop the space that we need to develop our anterior guidance. So here's our wax up done, my prototype's done. It's then a matter of getting into the mouth and doing our tooth preparations, immediately sealing the dentine when required, and putting our prototypes in. And of course, as soon as the prototypes have gone on at this increased vertical dimension, we've developed our correct overbite and overjet. The back teeth are no longer in contact because here we're using the Darling appliance principles. So I've prepared upper 5 to 5 and put the prototypes in place. The back teeth are now 1 to 2 millimeters out of contact, and we're now going to wait with these teeth in their provisional prototype restorations for a period of 3 to 4 months while those posterior teeth now just over-erupt. And once they've over-erupted and we've established that same 5 principles of occlusion, we'll do some minimal shaping on the anteriors to refine his guidance. And we then take impressions, putty matrices, custom-made incisal guidance table, and we copy his restorations in his final definitive restorations. So here he is now with his smile, and the most important thing I want you to look at aesthetically is looking at his lip here. Look how the lip has changed. We started out with his lip like this. We tried to do our imaging. His lip is still very, very unrelaxed. It's very, very tense. And of course now we've put his prototype restorations in place. He's relaxed a little bit more, his lips relax, and we can see a much easier, smoother, relaxed face. His restorations go in place, again increasing the vertical dimension, and his anterior view, and again we finish off with an occlusal splint. Obviously once a bruxist, every time a bruxist. We can't stop somebody bruxing. We can give them a splint to reduce the force of bruxing, reduce the amount of time that they brux, but if somebody is a bruxist, they're always going to brux. And if we put anterior restorations in that are made of porcelain, these are Emax restorations, then there's always the chance that on the bruxing side, then he could fracture those restorations. Now let's look at diagnostics and how we go about this particular case. We've looked at the principles of occlusion we're trying to get in. Let's look at the diagnostics. Let's look at this gentleman. This gentleman is called Ivor, and you can probably look at his face and visualize what his teeth are going to look like. He's overclosed, his face is rather sweaty, he doesn't look particularly a healthy man, he's overweight. Okay, we look at his OPG x-ray and we see missing teeth in the lowers, and that's going to probably suggest to you that he's going to have some over-erupted uppers. We see a combination of large numbers of restorations and worn dentition. So when we look inside his mouth, let's look at the teeth. The teeth are very, very worn. And with his worn teeth again comes the thought process to you, okay, we're going to have to restore those teeth. I'm going to restore those teeth with some crown work, some bridge work. Okay, at what vertical dimension am I going to work? Are we going to work at an existing vertical? If we do, that means putting crown and bridge work on where we have to drill his incisal edges down by 2 millimeters. That doesn't seem particularly logical. He's got worn teeth and I'm now going to wear his teeth down even more. Next vertical to choose from is to not prepare on the incisal, just prepare axially. So I could do that, and I could therefore maybe increase his vertical dimension by 2 millimeters here, and maybe not prep the palatal of the uppers, so maybe 3 millimeters, increase his vertical dimension by 3 millimeters. We have to try to consider, has this patient having his wear, is that wear occurring rapidly or is it occurring slowly? We'll see that in a minute when we look at some photos. Okay, and one of the things we look out for is that if the patient is a bruxist and also at the same time he's got erosion taking place, and we can see here that he's got the classic erosion and cupping and lipping of the enamel, then it's very often the fact that we've got accelerated wear. Erosion and attrition, bruxing equals accelerated wear, and that usually means that he's overclosed and the vertical dimension has been reduced. We look at his maximum smile, so let's take some photographs. We look at his maximum smile. This is his maximum smile. And we should be seeing a lot more tooth in here. We should be seeing lower tooth and more upper tooth. We start with our diagnostics. Our first thing is mounted study casts. So we take a face bow, we take upper and lower impressions, we mount those in our semi-adjustable articulator, And we now start to work out, if we are going to increase that vertical dimension, how much by, and if we are going to increase it by a certain amount, where are we going to put that space? We've mentioned already, if I want to increase his vertical dimension so it makes him look better looking, it makes him look slightly fresher, younger in the face, I've got to increase his vertical dimension by 5 millimeters. Therefore, the question to you is, if I'm going to increase by 5 millimeters, where is that 5 millimeters going to go? Is it going to go on his lower teeth? Is it going to go on the upper teeth? Is it going to be 2.5 millimeters upper, 2.5 millimeters lower, 3 upper, 2 lower, 1 lower, 4 upper? Where are we going to spread that? We have to have something in the science that we can go back to and decide where his occlusal planes should be. So it's going to be the occlusal plane, and it's going to be the lower occlusal plane that determines exactly where that space, that 5 millimeters, is going to go. And we know certain things about the lower occlusal plane. We know that as a plane you need at least 3 points for a plane. 2 anterior, 1 posterior, or 2 posterior, 1 anterior. And we've got certain planes that we work to. Imagine you're doing a set of dentures now. Okay, as you do a set of dentures, you've been taught to do the lower occlusal plane first and to put the lower occlusal plane so it's roughly at the commissures of the mouth, commissures of the lips. You've also been told to make the lower occlusal plane so the incisal edge is in the right position. So the anterior part of that lower occlusal wax bite block should be anywhere between probably 1 to 3 millimeters above the lower lip. That will give the normal aesthetic position of his lower incisors. But what about posteriorly? Posteriorly, we go to the retromolar pads. And we know that the retromolar pads do not change throughout life. So our posterior orientation are 2 points to get that plane. Posterior references are around about 1/3 of the way up the retromolar pads. And we know that because the retromolar pads do not change. They're the only landmarks in the mouth that do not change depending on bone loss and age. So we take that 5 millimeters that we've decided we're going to open him up by, and we're now going to put the lower occlusal plane in the correct position. At this stage, I have no idea if that means increasing the lower occlusal plane by 1 millimeter, 2, 3, 4, 5. It doesn't matter. We put the lower occlusal plane in the right position first. And for that, we go to those 3 places. We go to approximately 1/3 to 1/2 of the way up the retromolar pads, both sides. And for our anterior determinant, we decide where his lower incisal edge should be. So the one thing we've not mentioned at the moment with Ivor is how old is Ivor? Ivor is 55 years of age. And if we look at our textbooks, a 55-year-old man, if you ask him to go like this and look at his lips in repose, a 55-year-old man should be showing around about 3 millimeters of lower incisal edge. So my anterior reference point should be 3 millimeters above the lower lip in repose. So we go to the lower lip and we now measure with our periodontal probe. We measure gently behind the lower lip. We put our periodontal probe behind the lower lip until I hit 1 incisor, 1 central incisor. I'm then going to measure the distance from that 1 central incisor to the lip, and then I'm going to add on the 3 millimeters. But hold on, and Ivor's 55 years of age, and we're going to do a reconstruction for him. The next question we have to ask ourselves is, Ivor, how old do you now want your smile to look? Because most people, when they're having this done, want to try to improve their appearance, make them look a little bit younger, a little bit more vital. So Ivor said, if you can take 5 to 10 years off me, Paul, that would be fantastic. So now, instead of being 3 millimeters above the lower lip, I'm going to reduce that to 2 millimeters above the lower lip to reflect a slightly younger appearance. So I place my periodontal probe behind that lower lip. I measure from incisal edge to lip and add on 2 millimeters. We now go and ask our technician to do our diagnostic waxing. But before we do that, part of my treatment planning is me at this stage to get a feel for what is going to be happening treatment planning wise. So now I've got my mounted study casts. They've been opened up by 5 millimeters anteriorly so that I can affect his facial aesthetics. And what I've done now is I've put a little rubber band around the articulator. That rubber band is passing around about halfway through the retromolar pads, both sides. It's also passing 3 to 4 millimeters above that lower central incisor at that reference point where I want it to be. And straight away I've got an instant picture of where my new occlusal plane is going to be. We know that occlusal planes are curves. Okay, this isn't a curved plane yet, this is just a flat plane. But this shows me the teeth that are over-erupted, that will now need to be either moved upwards or ground down. It may well be part of my treatment planning for this is periodontal surgery, crown lengthening, endodontics, move those teeth upwards. It could be that we take those teeth out and put implants in, or it could be that we accept a non-ideal occlusal plane. So all these things are now going through your mind in terms of treatment planning. Next thing we do is we take our rubber band off, but just mark this with a pencil, so I can now see where the occlusal plane is going to be in a pencil. And finally, as the initial part of my diagnostics, is I now grind down the upper teeth to that lower occlusal plane. That will now give me the space to wax up my lower teeth to that new occlusal plane. And for that, we go to something called a Boyle's plane analyzer. This is something that most denture technicians should have. Don't be confused between denture technicians and crown and bridge technicians. Crown and bridge technicians will never have heard of this. Most denture technicians will. It's a simple piece of plastic that has the average curve of Spey, curve of Wilson, and curve of Monson actually made into it. So as you can see, this is a horseshoe piece of plastic. You may be able to see that there's a curve on it from buccal to lingual to lingual to buccal. There's our curve of Wilson. You'll see in a minute there's a curve from the posterior to the anterior. There's our curve of Spey. So what we do, in fact, is we rest this Boyle's plane analyzer on the retromolar pads halfway up, as we've decided. We wax up one lower central incisor tooth to its correct size. And remember, that's 2 millimeters above the lower lip in this case. I've now got 3 points, and I rest my Boyle's plane analyzer on